Welcome back to Diabetic Foot Files. This is Dr. G. Happy Hump Day. So, imagine this. A patient walks in with excruciating foot pain, but the wound doesn't look that bad. There's no massive infection, there's no obvious signs of trauma, but there is tissue dying. The tissue is dying. And why is that? Because the problem isn't the skin, it's the blood itself. So today we're going to dive into sickle cell disease, which is a condition where oxygen delivery fails, microvascular collapse, and the body literally chokes on its own tissue. Some people are familiar with the term sickle cell. I had a friend growing up who had sickle cell. So, what is sickle cell disease? At its core, sickle cell is a genetic disorder of hemoglobin. So, normally, the red blood cells, which are flexible, round, and smooth, easily pass through the capillaries. In sickle cell, the hemoglobin S causes the red blood cells to become rigid, sticky, and crescent shaped, aka sickled. And these cells can cause a blockage of the blood flow. They get stuck in the microvascular and can cause ischemia and infarction. So, who discovered sickle cell disease? So, sickle cell disease was first discovered in 1910 by a Chicago physician named James Herrick. He observed a peculiar, elongated, and sickle shaped red blood cell in a dental student from Grenada. This was the first documented molecular disease, and in 1914, Linus Pauling identified it as the hemoglobin abnormality, aka hemoglobin S. So, the pathophysiology of it is the mutation in the beta globin gene, which produces the hemoglobin S. And under stress, like low oxygen, dehydration, infection, the red blood cells become rigid and sickle shaped and can cause vascular occlusion and ischemia and tissue infarction. So, when we're trying to break it down to a molecular level, the problem starts with the hemoglobin S. So, this is a mutation in the beta globin gene. So, it's supposed to make glutamic acid, but it turns out it makes valine substitution. Okay, so that's from the mutation. And so, what happens next is the low oxygen, the hemoglobin S polymerizes, and the red blood cells distort, which causes sickling, and the cells become more rigid and they cannot deform, and this causes or results into capillary obstruction, which causes microvascular occlusion. So this is not just a blood disease, this is a microvascular catastrophe. So one of the hallmarks of sickle cell disease is something called vaso-occlusive crisis, VOC. And what is that? It's an episode, or they have multiple episodes, where the sickled cells block the blood vessels, cut off the oxygen supply, cause severe pain and tissue ischemia. So what are the triggers? Triggers are dehydration, infection, cold exposure, hypoxia, and stress. And clinical features are like bone pain, joint pain, soft tissue ischemia, foot and ankle pain without an obvious cause. So, how do you test for sickle cell? So, you could screen. Screening includes sickle cell solubility test. This is a fast test, but not definitive. Confirmatory test, which is gold standard, is a hemoglobin electrophoresis. This helps to differentiate hemoglobin A, hemoglobin S, hemoglobin F, hemoglobin C. And you can do additional labs like CBC, which will show anemia. You can do a reticulocyte count, which will be elevated. You can do a peripheral smear, which will show the sickle cell, or you can do a LDH or a bilirubin, which shows hemolysis markers. But in wound clinics, many patients do not know they have the trait or a mild case of the disease. Okay. And like we said, what when I'm mentioning trait, what is a sickle cell trait? Sickle cell trait is genotype for that is a hemoglobin AS. So they have one normal gene and one gene, and they're usually asymptomatic. But it is clinically important because under stress, like hypoxia, dehydration, anesthesia, can cause it to sickle. And this would cause an exertional collapse, renal issues, rare ulcerations, and, you cannot miss a trait as a benign thing, especially in surgical patients. So why does this matter for us as podiatrists or in our field lane? Because it's diabetic foot files, right? So it's that's real because for podiatry and wound care, we see things like chronic ischemia, which, microvascular blockage equals poor perfusion, tissue becomes hypoxic, and this causes delayed healing. So sickle cell patients actually do get ulcer formation. Sickle cell ulcers typically occur around the medial and lateral malleolus, and you have to remember it usually resembles venous ulcers, arterial ulcers, and can resemble diabetic ulcers. But I usually think arterial ulcers most of the time, but they are driven by microvascular occlusion, not just a macrovascular disease. And this is where clinicians can mess up. So location differences, like I said, sickle cell ulcers usually are the medial and lateral malleolus, the distal tibia. Really, I've never really seen one on the plantar pressure points. And you have to remember a lot of diabetic foot ulcers are at the plantar surfaces on pressure points, secondary to neuropathy driven and pressure driven, like met heads or heels. And like we said, with sickle cell ulcers, their ischemia is from microvascular occlusion, and the hemolysis causes a nitric oxide depletion, which causes a chronic inflammation. Diabetic ulcers, they're neuropathy driven, pressure driven, and sometimes ischemia driven because it's macrovascular. So clinical appearance also when it comes to sickle cell ulcers, they're usually shallow but very painful. Irregular borders, often recurrent, minimal callus surrounding hyperpigmentation. So you're also going to think maybe venous, right? Then diabetic ulcers, if it's neuropathy, usually painless, okay? Callus edges because of the pressure, deep associated with deformity like, plantar pressures on your foot, plantar flex, metatarsal head, so on, so on. So what is a key clinical clue? So if you see somebody with severe pain, ulcer near the ankle, minimal callus, younger patient as well, because think sickle cell before you think diabetes sometimes when it comes to that. Then pain disproportionate. This is a key clinically. Pain is often way worse than the wound looks because the ischemia is deeper than the surface appearance. There is nerve irritation as well as infarction. And then when it comes to infection risk, necrotic tissue, there's going to be bacterial colonization, impaired immune function, functional asplenia, okay, which increases your infection risk. And common organisms that do infect sickle cell ulcers are Staphylococcus aureus or Salmonella. That is especially important. Now, osteomyelitis in a sickle cell patient. So this is like board level pearl, okay? So in sickle cell patients, think Salmonella first, okay? Unlike diabetic foot ulcers with OM, right? Diabetic foot osteomyelitis are usually polymicrobial. Sickle cell osteomyelitis is usually hematogenous spread, okay? So why is that? Because of the bone infarction, because it's dead bone and the bacteria can seed easily. So what are systemic complications? Sickle cell does not stay local. Major complications are stroke, acute chest syndrome, kidney failure, renopathy. Our foot relevance is the chronic hypoxia, which can cause more poor delayed wound healing, and multi-organ stress, which can delay recovery as well. And like we said with diagnosis, hemoglobin, electrophoresis is gold standard, confirms the hemoglobin S, okay? And then CBC will show anemia and reticulocytosis, okay? Now, can a sickle cell get foot ulcers without diabetes? Absolutely. With the mechanism of chronic hypoxia, the repeated vaso-occlusive crisis, poor oxygen delivery, and skin breakdown, they don't need neuropathy and hyperglycemia. It's a pure ischemic and inflammatory pathology that's going on. So, how many patients would have or at risk or have the possibility of having both diabetes and sickle cell? There is a limited exact overlap on data, but sickle cell prevalence is about approximately 100,000 in the United States. It's much higher in Caribbean populations. Diabetes prevalence increasing in sickle cell patients due to aging population and improved survival of the sickle cell patients. So studies suggest about like 10 to 20% of all adults with sickle cell may develop diabetes or glucose intolerance. Okay. So the overlap is growing and wounds can become a mixed etiology. So how do we treat it? For the vaso-occlusive crisis, acute management needs IV fluids, oxygen, pain control, treat the underlying trigger. Okay. Disease modifying therapy, they have things like hydroxyurea, which increases fetal hemoglobin HbF and reduces the sickling. Sometimes they need blood transfusion, which reduces the hemoglobin S concentration and improves oxygen delivery, as well as there are advanced therapies like bone marrow transplant, which is curative in some cases, and gene therapy, which is emerging. So, wound care strategy, okay? So, key principle oxygen is everything. Remember, oxygen is our healing currency. So, you optimize perfusion, you consider adjunct therapy like hyperbaric oxygen. This is mostly case dependent. Gentle debridement. Remember how I love me some debridement, okay? And I can go in there, but when it comes to somebody who has sickle cell or even ischemia or anything like that, avoid aggressive tissue removal. It can risk worsening the ischemia. That's why diagnosis is such a key part of this. Infection control, early antibiotics. Watch out for osteomyelitis and pain management. This pain that these patients are experiencing is not exaggerated. This is real ischemia. If you don't know how ischemia pain feels, you see when people get choked, they don't like it. They just pass out. Imagine something choking your limb or like a real hard tourniquet for the longest time. Nobody can handle that pain. Okay. Nobody can have a localized area squeeze. It's horrible. So their pain is not exaggerated. Now, compression, be careful, okay? If it has a venous component, avoid definitely any arterial compromise if suspected. I wouldn't suggest it, to be honest, okay? So what I already told us what we see in our clinics, but it is often misdiagnosed as a venous ulcer or a diabetic ulcer, okay? But clinical pearls are if you see severe pain and a mild wound, think possibly make sure rule out sickle cell ischemia. When it comes to osteomyelitis in a patient who has sickle cell, think Salmonella and healing, delay in poor care, think systemic, and always assess hydration and oxygenation. So when it comes to debridement, like I said, debridement can cause stress and hypoxia risk. So you have before you cut any patient who has sickle cell, you have to check their hemoglobin, you have to check their oxygenation, you have to check their hydration status, and avoid aggressive debridement, especially if the patient is unstable or going through an active crisis. So bottom line is not all foot ulcers are diabetic ulcers, and we all know that. Sickle cell ulcers are a vascular ulcer as well as inflammatory wounds, okay? They require gentler debridement, systemic optimization, and a multidisciplinary team no matter what. If they have a wound, multidisciplinary team. And if you don't understand that, play the episode again, okay? Or all the others, suppose. So, sickle cell teaches us something critical. Not all wounds are about the skin. Some wounds begin in the blood, in the genes, and in oxygen itself. And you know, we're not just treating the surface, we're treating the disease too. Okay, so this is diabetic foot files, and this is Dr. G. And take care of your feet because they take care of you.